Hi, hope you're all having a good day. So, you all know what is an emergency. You heard of it. So, what exactly is an emergency? Anything which emerges with an urgency. It can be anything. It comes out with an urgency is called as an emergency. So, how to handle it? We have to be prepared. Only when we are prepared for an emergency normally ceases to exist. Because, as I said, it's emerging with an urgency. And when you anticipate the urgency, it's not an urgency. We know it's going to happen and we know how to handle it. So that's why it's very important to know the three hallmarks of any emergency for that matter that we come across in our routine dental or medical practice. Okay. It's prevention, preparation, and the management. Prevention. How to prevent an emergency? Because by preventing an emergency, we can save a lot of lives, a lot of catastrophe, a lot of uneasiness in the practice. And once you anticipate an emergency, are you prepared to manage it? Preventing is not alone. Sometimes it happens. When it happens, are you prepared? Prepared, it doesn't mean that you have all the armamentarium at your clinic or at your desk. Are you knowledgeable enough? Even having a knowledge of identification, a knowledge of management of an emergency also comes into the preparation of that. Once you are prepared for the management or identification of an emergency, then comes the management of it. That's adequately managing the patients. That requires both your clinical skills and your armamentarium to be at your disposal to maintain an emergency. Now, today, one among those emergencies is called allergy, which I'm going to talk about. I'm Dr. Santosh. I'm an additional professor in the Institute of Medical Sciences, Raipur. I'm a oral and maxillofacial surgeon by profession. What is an allergy? We all say, we have somebody's got a food allergy, somebody's got a cat allergy, somebody's got hay allergy, dust allergy for that matter. Allergy is, in general, it's a hypersensitivity state. It's usually acquired through an exposure to a particular known allergen. Note it again, exposure to a particular allergen with re-exposure to the same allergen produces a heightened capacity to react. I want you to ponder about here again. Exposure to a particular allergen, and with a re-exposure, there is a heightened capacity to react. Why I'm stopping here for a moment and reading this definition for you very clearly is, again, allergy is not always caused by the first exposure. It's a re-exposure which leads to a heightened capacity to react. So this hypersensitivity state can be mild, which can just have a couple of either rhinitis or a small itchiness or some sort of an erythema on the skin, and goes away for a short duration of time, like a couple of minutes or maximum up to 48 hours, or it can be an immediate life-threatening reactions which can lead to a catastrophe and even death of the patient. So you have to be aware of both sort of an sequelae of allergy for that matter. How is it? As I mentioned, it always needs to have a sensitization. That's called as a priming dose. It's a sensitizing dose. That what happens with that is, with the contact with the allergen, that's your antigen, there will be an sensitization of the immune system of the body. The immune system of the body might be your neutrophils or your basophils, and for that, the priming needs to happen at the lymphocytic level. The main appropriate cells, the B and the T lymphocytes, which gets primed up, and they are ready to take up any other subsequent injury by the allergen. At that point of time, when there is a shocking dose, that is your secondary dose, that's called a subsequent dose. When the subsequent dose of the same allergen, which is already been sensitized by the lymphocytic mechanism of the body, is exposed to the person, that manifests into an acute or a full-blown allergic hypersensitivity reaction. So I hope you all are clear on this part. We have got sensitizing dose and a shocking dose. Now, other important terms which you come across in this is allergen, anaphylactic, anaphylactoid, angioedema, antibody, antigen, pruritus, and urticaria. These are different terminologies which we come across when we read about allergy. What is an allergen? It's anything which is not innate in the body, which is supplied or which is ingested into the body, or it enters the body system, which can elicit an immunological response to the T and B lymphocytes. It's called as an allergen. Anaphylactic means without protection. Ana means no. Protection. Phylactic is protection. The body is unprotected for this sort of an allergen, can lead to an anaphylactic reactions. So this hypersensitivities are basically of different types. Now we all know about it. We have read about in our basic sciences classes. You've got type 1, type 2, type 3 and type 4. Each type has got a different mechanism by which it works and what leads to clinically. And we are, as a clinicians, are supposed to know it so that we can anticipate it and we can address the same. Type 1 is a classical one. It's called as anaphylaxis, and it's usually immediately, and it's usually an antibody mediated. The principal antibody which is mediating the mechanism of anaphylaxis is immunoglobulin G. It usually takes only a few seconds and minutes, probably maximum 5 to 10 minutes. The reaction of anaphylaxis usually sets in. What leads to it? Anaphylaxis. It can be drug, insect, or any venom. It can lead to bronchial asthma, allergic rhinitis, urticaria, hay fever. These are the different clinical manifestations of a type 1 hypersensitivity reactions. Type 2 is cytotoxic, that is anti-membrane, the cellular membrane. There is a response to the cellular membrane of the body. It's a cytotoxic, when the cells itself becoming toxic for that matter. In this, usually have an IgM mediated, that is immunoglobulin M mediated activation of the hypersensitive reaction. The good example for this is transfusion reactions, wherein which a new cells are introduced into the body by itself. Your blood transfusion, new RBCs, new platelets. These in turn leads to a reactionary state of hypersensitivity that usually leads to cytotoxic reactions. It can be even hemolytic anemia, and very rarely certain drugs also can lead to a type 2 hypersensitivity reactions. Now, coming to type 3. Type 3 is purely, it's an immunological complex. Means it's more like a serum sickness level, where again it's normally caused due to an immunoglobulin G, but it usually elicits at a slightly later. So it doesn't take minutes. It usually takes 6 to 8 to 10 hours for the responses of a type 3 hypersensitivity to show up. It can be an occupational allergic alveolitis or hepatitis, viral hepatitis, or a serum sickness. And these are the different manifestations of immunologically mediated immune complex type 3 hypersensitivity reactions. The last is a cell mediated. Means a cell by itself, a certain cells are delayed response. It usually takes later, normally around 48 hours or so. Like examples of a graft rejection, like you do a transplant, heart transplants or a kidney transplant. The body responds it with a hypersensitive reaction. That's what you might have heard doctors saying, yeah, we did a kidney transfer, but the patient didn't accept the graft rejection. Host versus graft rejection principles works in this. Even a tuberculosis, like tuberculosis and mycosis, and even a chronic hepatitis are the examples of these type of cellular mediated delayed response of hypersensitivity. So with this different type of hypersensitivity in question, with all these type of irrespective whether it's type 1, type 2, type 3, the response, the ultimate outcome has to be mediated with one of these lymphocytic cells. So we have B cells and the T cells. So you can see the classification which says normally these anaphylaxis, atopy, antibody mediated cell damage, serum sickness. These are the things which normally mediated through a B cell response of a hypersensitivity. On the contrary, a chronic infections like hepatitis and even the contact dermatitis is usually caused due to a delayed T cell activation of that. And this is just a chart to depict the different type of hypersensitive reactions. Now, sticking on to what we call as an emergency, which we come across in our in our practice, is anaphylaxis. Anaphylaxis is a classical example of a type 1 immediate hypersensitive reaction which can be a catastrophe if it is not managed adequately or diagnosed adequately in time. So that is the reason why here I expect everybody of you to be a little bit cautious and understand the principles of anaphylaxis and the pathophysiology of anaphylaxis, how to anticipate it, how to elicit, and how to manage an anaphylaxis in your practice so that you can save some lives in your life, definitely. Now, as I mentioned, anaphylaxis is an amplified, harmful immunological reaction that occurs after re-exposure to antigen. Watch this word again, re-exposure. It does not happen always with the first exposure. Re-exposure, and it is the opposite of a prophylaxis. What happens in a prophylaxis? We have taken prophylaxis. I'm sure everybody have taken prophylaxis for your COVID vaccinations now. We take a first dose, we take a booster dose, we take a tertiary dose like in hepatitis. What happens is with an addition of doses, the immunological protection increases. Hope you understand. First dose, a second dose, we call it as a booster dose, and these booster doses increase the immunity of a person. But unlike in anaphylaxis, the subsequent exposure of this is harmful for the patient. It's not a protection for the patient. That's the main difference of immunological response of anaphylaxis as compared to a prophylaxis. So this true anaphylaxis is a systemic reaction caused by an antigen specific IgE molecules, which normally these IgE molecules attaches to certain cells in the body which has some chemical mediators which releases, and these chemical mediators are potentially harmful, which can lead to a catastrophe. So we have everything. All the mediators which leads to a life-threatening situation, our own body has it. But only this is a reaction that a hypersensitivity state is a state in which these mediators are released into the body, can lead to a catastrophe at the later date. Now, let us understand. I'm sure it's a little bit confusing on this scale. Just put it in white and black. Let's go. Prior to this, only in 1903, Portier and Richard discovered that immunization, when doing an immunization for the guinea pigs with a toxin from a jellyfish, they could sensitize them. So rapid onset of breathing difficulty, influx of fluid into the lungs with acute bronchospasm, and the death of the guinea pigs. That's when the discovery of anaphylaxis came. As I mentioned, means there is no protection. The body has lost the protection. So, when they say no protection, why? Body has an innate system. It's got responses. We have got anatomical barriers like skin. The skin doesn't let anything enters, and you have got you got our immunological mediators, that inflammation system, that you have a phagocytic cells coming, and your neutrophils, later the lymphocytes. Everything normally takes up any foreign body like microorganisms enter the body. So that's a mechanism. And we produce enzymes, we produce antibodies. Specifically, the protective one is immunoglobulin A. These are the different mechanisms we have. In spite of this, that antigen is one which stimulates the antibody. It has basically 3 types of different reactions which can happen in a body. Number 1, the antibodies are produced that combine with an antigen and neutralize and change and become inoculous. That's what I said, IgA. When you have an allergen coming into the body, you have an antigen, the antibody of the body goes, it's a defense mechanism, it takes care of the antigen, it nullifies. That's matter settled, we don't have to worry about it. Most of us have this mechanism wherein which we don't end up having any allergic reactions for that matter. Type 2, the antigen-antibody combination which occurs in the blood vessel, like in a chemical cellular mediated one, and it increases to a magnitude wherein which that antigen or an antibody attached to the cells, they've joined together and they occlude it, means they form an actual precipitate. It can be a cytotoxic, and it precipitate in the blood vessels, and that can lead to a small occlusions in the peripheral vasculatures, and it can lead to erythematous patches, of course. This type of reactions, wherein with the depositions or the precipitations in the blood happening because of the antigen-antibody reactions, is a classic example of a type 3 hypersensitivity, that is arthritis reactions. And the type 3, the third type, is antigen-antibody union. The union of these two activates proteolytic enzymes, means the enzymes which can rupture the proteins of the cellular membrane. That can lead to degranulation, means release of chemicals which is normally present in certain cells, which I'm going to tell you in a couple of slides now, that gets released. These chemical mediators, type 1, not to worry, type 2, the precipitation, Arthur's reaction, probably a dialysis or probably a kidneys take care of it at the times, and certain mechanisms will help you. Right. But in a type 3, an antigen antibody activation happens when there is a mediators released in the body. These mediators the one which leads to a complex system called as an anaphylaxis. Now coming to the pathophysiology, as I mentioned again, there's 2 doses are required. The pathophysiology of usually has 2. 1, sensitizing phase. Number 2, challenging phase. So let's understand what is it now. Sensitizing phase. This picture clearly depicts both the sensitizing and the challenging phase. Sensitizing phase is a phase in which a patient or an individual are exposed to an allergen, probably which is allergy. We call it as an allergen rather than antigen at this point, because this is going to elicit an allergic response there. This allergen or an antigen, when it enters the plasma, when it goes in the cell, it produces immunoglobulin E, IgE. This is specific for that particular antigen. These IgE cells, you can see there, these IgE that looks like a T-shaped, the Y-shaped blue color one in the picture, this attaches itself to the cells which have a storing capacity of all this chemical mediators, like your mast cells or your circulatory basal cells, and which is freely available in the bloodstream. Once they are attached, on a subsequent phase, when there is a repeat challenge, when the repeat challenge of a same allergen entering into the plasma, entering into the blood, now you have got an IgE already produced in the body, and you've got an IgE attached and ready to attack on your mast cells and the basophils. When these allergens get itself bounded to the IgE molecules which are attached itself on the receptors of the mast cells and the basophils, leads to degranulation, means leads to proteolysis of the cell that releases a lot of molecules, means your mediators. These mediators are the one which leads to a clinical symptoms, that what we call it as an anaphylaxis, an allergy reaction. What are these reagents? Like histamines, leukotrienes, and cytokines. Let's go in detail about it. Now you have a mast cell. So in normal mast cell, they have innate lot of chemical mediators by itself. It's called like a heparin is around 70 to 90 micrograms, histamine 10 to 15 micrograms. These are the normal constituents of a mast cells or even a basophils for that matter. Once the receptor is activated, the IgE complex is activated, and the degranulation of these mast cells, the basophils, happens. These the different chemical mediators, when they're released, predominantly the histamine, it's a main culprit. You cannot forget the name of histamine, because this is the biggest culprit which leads to a lot of allergic reactions. That's why we, even in the medication part, you might have read in your pharmacology classes that antihistamines are the drug of choice. Okay, let's get back to this. Histamine, it leads to increased vascular permeability. What do you mean? Let's understand individual thing, because this slides, if you understand the individual chemical mediators and what it causes, you understand the whole pathophysiology of an anaphylaxis or an allergy in particular. Increased permeability means what is happening? The blood vessels become more permeous. When it more permeous, the intravascular volume is getting decreased, because there is a shift of blood or your plasma from intravascular to the extravascular structure. When there is an increased extravascular volume, we call it as edema. Understood? Intravascular, when it goes to extravascular, that concept is called as an edema there. With the edema, you might have heard about laryngeal edema, you got a facial edema, widespread edema, according to the allergy, is caused because of this increased vascular permeability, mainly caused by histamine, and also it's caused by, in the later stage, by even prostaglandins also. And the second most important thing is contraction of the smooth muscles. Smooth muscles, we have got an abdominal smooth muscles, you've got a laryngeal smooth muscles in the breathing pathway, and even in the lungs you've got a smooth muscles. When this acute contraction of the smooth muscle happens, that's when the patient get abdominal cramps in case of anaphylaxis, and breathing difficulty because of the contraction of the airway can lead to can be caused due to these histamine reactions. Then the second molecules is leukotrienes, and this is also very notorious because this specifically contracts the lung smooth muscles, that's leading to a bronchospasm. So bronchospasm, difficulty in breathing, patient unable to breathe, probably trying to gasp, probably even the saturation drops down if it not adequately addressed on time. It can be a breathing difficulty, and a patient can be hypoxic also. Serotonin, contraction of smooth muscle, and eosinophilic chemoattractive factors, prostaglandins, as I said, it's to increase the vascular permeability and contraction of smooth muscles again, and platelet adhering factors. These factors at the later stage, because not only the mast and bast cells, mind you, even platelets have an abundant amount of these histamines stored in the platelet also. So on a later stage, as the time progresses, like probably a couple of hours from now, after the initial insult, the platelets also start releasing the histamine. That is the reason why a prolonged effect still lingers on. So that's the reason why a long-term, at least in 48 hours, management with antihistaminics or anti-allergics are always required for the management because of the late release of these histamine from the platelets. Now once you understand how is this, everything is what's causing this anaphylaxis, let's understand what exactly happens in anaphylaxis. We understood from where the mediators come, what is histamine, it's bronchoplasm, spasm, and soft tissue constructions, and erythema and everything. But how does it manifest? Manifestations usually is in two stages. What is initial phase and the secondary phase. The initial phase is predominantly by your mast cells. There's no second thoughts about it. So it's characterized by, as I said, vasodilation, vascular leakage, that is transfer of intravascular contents to the extravascular contents, leading to a widespread edema, smooth muscle spasm, evident. Usually this whole sequence, you can see it in the initial couple of minutes to maximum 30 minutes or so, something like that. So in hours time, the initial phase is slowly, it doesn't stop there, it's taken over by the secondary stage. Mind you, it takes over by the secondary stage. That's where your secondary mediators comes in. Your secondary mediators are eosinophils and your platelets in the later stage. These also start secreting the chemical mediators. So, though the manifestations starts acutely in the initial phase, it keeps prolonging over a period of time because of the multiple cellular components which are getting into action and leading to an emergent situation called as an anaphylaxis is set in. So, what happens when this whole sequelae happens? Now, there's a different systems are involved. Number one, upper respirators. And if you take up the upper respiratory system in a simple allergy, it can be a runny nose. We call it as a rhinorrhea, or a sneezing, angioedema, stridor, life-threatening. Stridor is life-threatening. At times you need to go for either intubation or you do an emergency tracheostomy to relieve the patient with a stridor. Respiratory, because of the bronchospasm, can be cough, wheeze, dyspnea, bronchoconstriction, and hypoxia. And ultimately can lead to anoxia if not treated in time. And as I said, because the smooth muscles are affected by your histamines, it can also lead to nausea, vomiting, abdominal pain, diarrhea. And the first one, as I said, to elicit is the skin, your flushing, urticaria, angioedema, and the most commonest is itching. The patient gets itching the moment you elicit the allergy. And the last one usually is your cardiovascular. That's normally at the end stage, probably as the disease progresses or the pathophysiology progresses, it enters to hypertension, tachycardia, widespread vasodilatation, increased vascular permeability, and end of the day the patient goes to a syncope. It's not just like a syncope which normally happens in dental clinic with a prick shock. This syncope means the patient is going for an unconscious stage, which can in turn leads to a cardiac sequelae of being a total cardiac arrest for the patient. But this all doesn't happen all of a sudden. The moment you give a prick shock and the patient gets an abdominal cramp, it doesn't go into cardiac arrest and just collapses. It gives time. It normally starts with the skin. You have an urticaria, your rashes, angioedema, your facial puffiness. Then it comes the exocrine glands, your runny nose, watering eyes. Most of your seasonal allergies, what we get, like for example, you've got dust allergy or winters, you have a runny nose. This usually stops at this level. It doesn't go beyond this. And the later stage, you get a GI spasms, a cramping. You get a widespread cramping on the patient complains of patient in your clinic. You've just given shot of LA or probably one drug you injected. He just mentions about some itchiness and runny nose, and he complains of being a discomfort in this. You have to think there is something happening. That's where as a clinicians our point is very important to know that allergy is not about only puffiness, allergy is not about only angioedema, allergy is not about anaphylaxis, is not about always going for a tracheostomy. Early identification at the skin level or a runny nose level, or the best is your abdominal cramping. Give him a shot, give him a shot of the drug which is to be required, give him an anti-allergics. You can prevent a catastrophe. Once it is not done, it progresses to the respiratory state. That's where the bronchospasm comes. Then you have to do airway management systems, and you need to end up doing a tracheostomy for the patient to relieve it, to give an adequate airway for the patient. And the later stage, if it's untreated till then, it can go for a cardiovascular system, because cardiovascular is also mediated by the mediators. As I mentioned, the chemical mediators, the leukotrienes has an effect on the card. Not only that, with hypoxia, there is an increased cardiac load. That increased cardiac load, seconded by hypoxia and widespread hypoperfusion because of the increased permeability, can end up patient into an afterload that leads to a cardiac arrest unrelated. So this is all a progression. So we don't want any patient to die on a dental chair or a clinic. So it's always better to identify and address to the patient as early as possible. How to go ahead about it? Now, these are the reactions and symptoms which normally skin reactions like urticaria or an angioedema. Urticaria is tingling and feeling of flushness and pruritus, and these are the signs which you can find. It caused mainly due to the increased vascular permeability. As I mentioned, the first sign from a histamine, first thing that a histamine does is you're increasing the vascular permeability. So you affect all the things which is related to a vascular permeability. On the second stage, you get the rhinitis, that's nasal congestion, nasal itching, laryngeal edema, and bronchospasm, and so on. So this is how a typical pruritus or urticaria looks like. You can see a widespread patches, you can see redness, your patients get a readiness, a puffiness in the face, and mind you, it's unlike any other disease. Like it's usually not symmetrical. It might not be you don't expect the edema to come on both sides of the face or both sides of the body. It might be asymmetrical. Like in the picture in the top, you see angioedema covering the eyes only on one side. On the second picture, the lady has got a bilateral one. It's not. It can be how it presents the way it wants. It cannot be predicted. You cannot say it is unilateral. It can't be bilateral. It can be different. But end of the day, yes, because of the increased permeability, there will be an angioedema, there will be a pruritus, there will be an itchiness, which the skin conditions comes in. Then next it goes to the nosy, stuffy nose, then it advances to the level of GI system where you got an abdominal cramping, and the later go to the bronchospasm and the cardiac. This picture here, you can see this. This is I'll forget about the loss of consciousness here. Hives is the nasal thing, Why is the breathing? You don't have to wait. Why is it breathing is such an important thing in an anaphylaxis? Yeah, though I said the bronchospasm happens slightly in the lead. It slightly means it doesn't wait for hours together. The whole thing as a sequence, it usually happens within 1 to 1 hour. So you have a time of 1 hour, but during the initial increased vascular permeability in the edema stage, the tongue is a highly vascular structure. A lot of blood vessels in the blood. So that means increased permeability in the tongue. It means edema in the tongue. What happens if the tongue edema happens? Of course, the tongue swollen down. Once the tongue swells down, it's swollen up, it blocks the airway. We're least worried about eating at this point of time, because life is more important at this point. When the tongue is increased, you can see it compresses the airway. It compresses the airway. Not only that, even the soft tissues along the trachea, they're all soft tissue that starts swollen up, because it's all highly vascular. Soft tissues are vascular. The moment it's vascular, increased permeability, that leads to an edema, and that leads to narrowing of the airway space. That's the reason why the patient goes to hypoxia and leads his consciousness. And over a period of, that's what we call it as a syncope. Unaddressed, it can have the sequelae. Once we are not able to, if you fail to identify at an initial stage, or till at least the bronchospasmic stage, if it goes to a CSF or a cardiovascular system, as I said, it's going to be a circulatory collapse. Why? Because of the increased permeability, a loss of volume, and the loss of vasomotor tone. Because of smooth muscle spasm, the tonicity of the vessels are lost. That leads to hypotension, decreased in blood pressure level, and increased venous capacitance. Means increased venous outload is more, because there's a lot of edema, the tissue keeps coming in, but there is no contractibility of the vasculature. Hypotension, that is a condition we call it as a shock. With this shock, the heart tries to manage. Our body is such a beautiful system, it tries to adopt. How does the heart adopt? By the decreased volume? By becoming a tachycardia. It tries to be tachyc. It keeps fluttering or keep contracting at a very rapid pace. That's where the tachyc happens. When the tachyc happens, it might be a non-specific. That can lead to a state might be dysarrhythmia. Means arrhythmia which is irregular, when the contractions are irregular. It can be a ventricular contraction arrhythmias, or atrial fibrillation, or these can be usually picked up on an ECG. This again be more catastrophic if the patient has got pre-existing cardiac disease. Fine, arrhythmia is set, but what if the patient is already a cardiac patient? Already he's undergone some cardiac procedure or valvular replacement, or he's got a pre-existing atrial fibrillation. This is going to be a very big catastrophe. You don't have time. The patient need to be collapsed. He is going to cardiac arrest. So end of the day, the cardiac arrest is, if nothing has happened, the end ultimatum, the patient goes to asystole. Asystole means there is no contractions to the heart. So then you don't have anything. You just have to start your ABG, that is cardiopulmonary resuscitation, has to be initiated immediately, and you need to call for help. Now, that's all about how starting from a simple skin erythema, death due to an anaphylaxis can happen. I will just try to explain to you the sequence of how it happens. Now, to summarize again, these are the primary and the secondary mediators of anaphylaxis: histamine, serotonin, eosinophilic chemotactic factors for anaphylaxis, slow reacting substance of anaphylaxis. And secondary mediators, we have lipid mediators like cytokines, leukotrienes, interleukin-1, interleukin-4, interleukin-5, and platelet activating factors. I told you how important these platelet activating factors are, because it even acts at the later stage. Now, this is again the pictorial summarization of how the whole mechanism works here, just to make sure you remember the whole sequence here. You got, this is a picture of a mast cell. You got a Y-shaped IgE receptors which is attached to the mast cells because due to the initial sensitizing dose. Once the antigen attaches to the IgE, that leads to degranulation at the initial stage, which leads to release of granules, it leads to an immediate initial primary response. That's histamine, proteases, and chemotactic factors. And on the secondary stage, that is slightly delayed, late phase, you get prostaglandins and leukotrienes are released from the same mast cells, which leads to a delayed or probably called as a late phase reactions. So this is how the whole pathophysiology of anaphylaxis is mentioned in this. Not only the mast cells, as I mentioned, other cells also releases substances here. Now, majority being the mast cells, we have got histamines, main culprit, prostaglandins and heparins are stored and released, and even the basophils again, histamines, but our regular neutrophils, that is your first line of defense in the body, that will release as PAF, that is platelet activating factors. When the monocytes releases PAF, that is platelet activating factors, which leads to in turn release of histamine from platelets. That's why that usually requires a higher amount of concentrations of antigens to do, but still it can be, if it is uncontrolled at the initial stage, it in turn activates the platelet degeneration and release of histamines. Now coming to the diagnosis, that's all about what happens. Now let's see how to diagnose and how to prevent it and how to treat it. There are mainly two different tests we normally can do. One is skin test. You all, I don't know how many of you have taken a penicillin shots. When I still remember when we were kids, we used to take shots of penicillin. Every time a penicillin was given, we used to get a test dose on a forearm here. We used to get it pressed. What is it? It's about? It's called a skin test, where we inject a small amount, this 0.2 to 0.02 to 0.03 ml of this any drug which you are suspected to be an allergen is injected subcutaneously. And leave it for 5 to 10 minutes. You can see the response. Maximum to 30 minutes, you can see a response. That response is called as a wheal and a flare. Wheal is central dot and a flare. The wheal you don't have to be a bigger one. Normally, I've seen my residents are waiting for a wheal to, probably a centimeter or two. No, it has to be around 3 or 4 millimeter thickness of a small wheal. And the flare, it means it's a flare is an erythema which spreads around the wheal. So this is a diagnostic tech. It means the patient is allergic to that specific drug. So you have to be a little bit cautious of that. The second one is a patch test. I'll tell you the significance of what is a patch test in the subsequent slides. Here, you don't inoculate anything. We don't give subcutaneous injections. Rather, you apply a topical gauze or whatever allergen you're talking about. You can impregnate on a gauze and a small patch. Keep it attached to the skin. You put it and tape it around the patient for 2 days. And after 2 days, you take a biopsy of the skin. You take a small pinch of the skin and take a biopsy. And to see what is the cellular response for that. In a non-allergic patient, you don't get to see a lot of inflammation happening underneath in the skin. But in a positive patient, when a positive pathogen, you can see eczema spot, that is erythematous patch reaction on the skin, and we see a lot of cellular infiltration by eosinophils, basophils, and lymphocytes underneath the skin. This is quite a confirmatory test for allergy. Skin test is what we normally do it on a clinical chair side, but patch test is a confirmatory test to find out. Why it is confirmatory? Because you can see this here. The initial response, like 15 to 30 minutes, normally in the immediate response, we don't do it. Only if you expect to be an allergy, a very severe allergy or an anaphylactic type reactions, you get an initial responses. Or normally you get a late response up to 4 to 12 hours. But in a later stage, you can see the delayed response. You can see the delayed and the SMS patch test. At the 12 to 14 hours, you can see all the mediators response are heightened only at the 12 to 48 hours. That is the reason why the patch test is quite diagnostic and quite confirmatory, because we are waiting for the 48 hours for the full potential of the immunological response to be active. Then you are microscopically confirming the infiltrate of these cellular responses, and that is the reason why it's a confirmatory test.